Okay, so the vessels that travel along the dermis and fatty tissue, whenever your body gets really hot, those vessels will dilate. So when those vessels dilate, now there's more blood traveling through the dermis section of your skin, that second layer of skin right in the bottom. And because there's more blood running through there, a lot of heat is carried in your blood. That allows for more blood to leave, I mean, more heat to radiate and leave the body. That's what that does. And that's why whenever you're really hot, sometimes your body gets flushed and red. It's because of the vessels that are dilating close to the skin and the dermis section. And it also allows for that heat to leave the body. Excretion, so again, that's through sweat. Excretion is taking elements out of your body, taking out hormones, regulation, all that stuff. It's taking out things from the inside of your body to the outside, and that's done through sweat as well. And shock impact absorption. When we're talking about just strictly trauma. So whenever you get impacted or hit by an object like a baseball bat, your skin takes a lot of that force and protects the internal organs to an extent. So 3 layers, there's the epidermis. Remember, epi means above. So it's the layer above, the top layer, epidermis. Then you have the dermis. That's where a lot of vessels travel through. And the subcutaneous layer is the fatty layer under the dermis. So it's the top layer of skin, the dermis, and then fatty tissue. Wounds are often classified as closed or open. So you have closed or open wounds. All that means is that if it's a closed injury, that the skin is intact. If it's open, that means the skin is broken because of the trauma itself. And here's a better visual for you guys. As you guys can see, the dermis is this top layer right here. This very, very top layer, it's all just skin dead cells. That's all that is. Because the skin, it gets created right here in this little section, and as it gets older and older and new cells are formed, the old ones get pushed up and they die. Then, like I said, here's the dermis section. You have a lot of blood vessels. These are the blood vessels that would dilate to allow for heat to leave and to cool you down. And your hair follicles are also located in this area. And sweat glands. Okay, so I'm gonna play this video real quick. So this word right here, integumentary, it's a fancy word for skin. So anytime you see this, if you don't know it yet, please write this down. This equals skin. Oh, hold up. I don't think I let the sound play. Let me redo that again. So play this, share new screen, share sound.
Skin consists of an outer epidermis and an inner dermis. The epidermis. The skin consists of an outer epidermis and an inner dermis. The epidermis consists of 5 morphologically distinct layers of keratinocytes. The epidermis provides a physical and chemical barrier, helps regulate fluid and temperature, provides sensation, assists with vitamin D production, plays a role in excretion, and contributes to self-image. Open wounds with damage only to the epidermis are called superficial wounds. The dermis supplies the epidermis with nutrition and support, houses the epidermal appendages, assists with infection control and thermoregulation, and provides sensation. Open wounds involving the epidermis and dermis are called partial thickness wounds. The subcutaneous tissue, consisting of fat and fascia, lies beneath the dermis. The subcutaneous tissue provides cushioning, insulation, and support to the overlying tissues, is an energy storehouse, and facilitates movement between structures. Wounds that extend into or beyond the subcutaneous tissue layer are called full-thickness wounds. Clinically, it is important to correctly identify structures within a wound, to know the depth of tissue injury, and to provide appropriate interventions.
Any questions about that video? No? All right. Go back to share screen. All right, so now we're gonna get into closed wound injuries. So with closed wound injuries, like I said, see internal injuries with no pathway. So that means that, let's go back to little Timmy. This means that you were playing baseball with little Timmy, right? You made little Timmy mad. Little Timmy hit you with the baseball bat in the stomach. So now that baseball bat may have not been strong enough to break the skin. So the skin's gonna be unbroken. However, your internal organs may not be strong enough to withhold the force behind that bat. So even though that bat impacted the skin, did not break the skin, and then that force continues to go throughout your body. It doesn't just stop at the skin. And even though that force may have not been strong enough to break the skin, it could have been strong enough to break an organ that lies behind that the skin. So that would be a closed wound because there is damage. There may be bleeding, but the impact wasn't strong enough to damage the skin or tear the skin, but it was strong enough to damage and possibly tear the organ directly behind that skin. And that's what a closed wound is. And of course, they range from minor to life-threatening, depending on location, the object, and the speed of the object. A contusion is just a fancy word for a bruise. So you guys should write these down, these definitions if you don't have them yet. A contusion is just a fancy word for a bruise. So when someone gets an eye, they have a contusion in their eye. I mean, when they have a black eye, it's a contusion. A hematoma is just a really, really big contusion. So a hematoma means that there's bruising, there's damage to vessels, there's damage to tissue, but it's bigger than a normal bruise because there was more damage that happened. So like it says here, similar to a contusion, but there's more tissue damage. There's just more damage, and it involves blood vessels. With the contusion, with this one up here, mainly you have tissue damage, some capillary damage. With the hematoma, you're looking at vessels that are a little bit larger that are being damaged. And I found a video on this, so I'm gonna go ahead and play it for you guys. See screen sharing has stopped, right? Okay. I think it's on here. First, hematoma. Here we go. Let me know if you guys can't hear it when it starts playing.
Hey everyone, welcome to the winter wonderland of Bellingham in the Pacific Northwest. We usually don't get this much snow, but it's been great. Basically, the whole city is shut down. So first of all, I want you to take a look at a couple of pictures. Yes, that's my leg. Yes, there's swelling, discoloration, nasty looking bruise with some swelling, some hematoma. I'm going to tell you how that happened and two critical mistakes I made that unfortunately is going to prolong the healing process. So stay tuned. Hey everyone, welcome to the front row with Ed and Elizabeth. So as you saw on those pictures, I suffered a fairly significant injury, which I made a little bit worse with a couple of missteps that I made. So I decided to make this video to talk a little bit about it and maybe if there's something that you can learn from my mistake. So if you follow this channel, you know that I like to play basketball. And I was playing basketball, I usually play in the mornings, and I accidentally took a knee right in the side of the thigh, which is not a big deal. Usually it results in a little bit of bruising and some stiffness of the leg. I was able to continue to play best I can, and it was Thursday morning, so then I went to work. So if I happened to see you in the clinic on Thursday or Friday, I had to come clean because I was noticeably limping. So by about Thursday afternoon, I started to get quite a bit of pain in my leg, and most of my job is standing up and moving. So I took a look at my leg, and not only was I bruised right here on the side of the thigh where I got hit, but I started to notice a little bit of pooling of blood down towards my knee. Now, if I was smart, I would have realized that I probably suffered what's known as a hematoma, And a hematoma is a breaking of the small blood vessels in our leg, usually because of some sort of impact. And what it's causing is a bleed internally, and blood's basically flowing into areas that it's not meant to be, which takes me to my first mistake of the day. I took 600 milligrams of Advil to help reduce the pain. What I should have done was taken Tylenol, which is acetaminophen, versus Advil, because what Advil does is actually inhibits the clotting process. So remember, I had this bruise, I had a little bit of internal blood vessel damage, so there was a little bit of a hematoma, some bleeding. So what do? I took Advil, which actually inhibits the ability of the body to form clots. And so I was perpetuating this internal bleeding a little bit. It took the pain away, but I wasn't helping my cause. Next day I wake up in a significant amount of pain, and there's quite a bit of swelling in my leg, and I can hardly bend my leg. So what do? Mistake number 2. I know, right? I'm not the smartest guy. Mistake number 2. So I go to the gym. I don't play basketball, but I go to the gym thinking that I'm going to get some range of motion on my knee because I still have to go to work and I can hardly bend my knee and I can hardly sit down in the car to drive. So I go to the Y and I get on the elliptical machine, I get on the bike, and yes, I did increase my range of motion a little bit, but what I also did was bring more blood flow to the area, right? Because that's what happens when we use the joint, we use muscles, it brings circulation, brings blood flow to the area. Well, I already had small vessel bleeding, so that just increased the pooling into my leg. So by the end of that second day, by now, I had pain and swelling all the way down into my calf, all the way down to my ankle. And I know I didn't injure that because remember, my initial impact was up here. By day 3 and 4, I had swelling, discoloration, heat all the way up and down my leg. And so I finally got smart and realized what was going on. So I stopped the Advil. I took a little bit of Tylenol if I needed for pain. I stopped going to the Y to work on range of motion. I just had a little light compression on there. And I did what I should have done at the beginning, which was not force the range of motion, worry about that later. First take care of the internal bleeding and the hematoma that was going on. So I elevated, ice, light compression, and Tylenol as needed. By day 9 and 10, I finally started to get some more range of motion. The coloration changed. You'll notice when you have a hematoma like that, it goes from this reddish brown to kind of this green, and then finally to a yellow, and then you know it's finally healing up as the body kind of reabsorbs some of that extracellular debris. How long does it usually take for a hematoma to get better? Approximately 1 to 4 weeks based upon the impact and also to what you do. So unfortunately what I did was probably set back my healing for about a week or so, but you live and you learn, and hopefully if there's something here that you guys can learn from the video and learn from my mistakes, that'd be great. If you have any questions, let me know. If you haven't subscribed to the channel, go ahead and do it. I try to post pretty regularly about stuff that might be helpful, and drop me a line. I'll help you any way I can. All right, take care, good luck, and enjoy the weather.
All right, so that's a hematoma. Any questions about anything that was in that video at all? All right, so we'll keep going. Share. Okay, so we talked about contusion, hematoma. Closed crush injuries is exactly what it sounds like. That means that a part of your body was crushed between machinery or two big objects or heavy objects, and as a result, there was a lot of damage, rupture, and possibly broken bones depending on the site. And a crush injury will most definitely at least lead to a hematoma. If it's in the arm and you have a crush injury on your forearm, that's going to lead to a hematoma for sure. Blast injuries, like it says here, it can include open and closed wound types. It depends on the blast, what kind of blast, the shrapnel that was with it. Was there shrapnel? It's a lot of factors always play. See, potential for massive internal damage is higher than with direct force. So with the blast injury, let me see. Some of you guys, one of you guys correct me if I'm wrong, but I'm thinking there's There's 4 phases to a blast injury. There's so initially when let's say a bomb goes off, right? If a bomb goes off, initially that force, that wave force from the blast itself will get to you before any objects or any heat does. So the actual blast injury creates a force, like a wind, like a wave force. That's the first phase. The second phase is the shrapnel actually hitting the body. So whatever got blown up, the second phase is shrapnel actually hitting the body. The third phase is the physical person hitting the ground or the wall from the blast injury. And the fourth phase should be environmental factors, smoke, flames, whatever happened because of the bomb, like after the fact. And then, of course, it depends on where you are. Are you in a factory? What the bomb was made of? All those things come into account for the environmental phase. So these are all different types of closed injuries. Like you guys can see, out of all these 4, which one would you think could have the highest potential for your patient to bleed out? I'll pick on somebody. See, David, you're the first one on here. David, out of these 5, which one do you think would have the highest potential for a patient to bleed out severely? What do you think?
Oh man, I really want to say the rupture of a hollow organ.
Rupture of a hollow organ? No. Anybody else wanna give it a shot?
Injury of a solid organ?
Yes. And why is that? Why do you think that is?
Because if it's solid, I would guess there's more blood in there.
Exactly. Yes. Your hollow organs are less vascular, meaning they have less vessels that feed it blood. Your solid organs need more blood, so therefore they're more vascular. So your patient, if they have a puncture or laceration of a liver, your liver is very vascular, and you have the potential to bleed out more with this than any of these other injuries. Now, anybody else, what can this right here, internal laceration and puncture? So the rib being punctured right here, or broken, not punctured, but broken, what can that potentially lead to? What kind of shock can that lead to? See, Andrew, I'm gonna pick on you for this one. So your patient has a broken rib. This is your patient right here.
Mm-hmm.
What can happen as a result? And then if you can't even tell me what kind of shock can form.
I mean, if the rib broke and it punctured a lung, that's most likely a spontaneous pneumothorax. But as for the shock, I'm not too sure on which type of shock. I know it's not infection, so it might be maybe pulmonary.
So you're partially right with the first part. So a spontaneous pneumothorax means that it happens spontaneously because of nothing. There was really no damage, no physical, nothing happened. Your patient spontaneous. So that's spontaneous. That means it just occurred. This can actually lead to just a regular pneumothorax, which can then develop into a tension pneumothorax. And if a tension pneumothorax progresses, what happens is your thoracic cavity builds up with pressure right on the outside of the lung. That pressure will collapse your lung, so that lung is almost not even good, not even functioning. On top of that, if the tension pneumothorax continues, it can apply pressure to the heart itself. So if the heart itself is obstructed, is being pushed down upon, then it can't expand and contract adequately, right? And that's called obstructive shock. So when there's an outside force not allowing the heart to contract and expand, it's called obstructive shock because the heart is being obstructed from doing its job right. Okay. Okay. Good try though. You got half of it right, so that's cool. That's good. Okay. Give me a second, guys. I'll be right back in like 1 minute. All right, I'm back, guys. Okay, let's keep going with this. All right, bruising. What did I say is a fancy word for bruising? And somebody spit it out.
Contusion.
Contusion. And what is the word for a really, really big bruise?
Hematosis?
Hematoma. Perfect. Awesome. Now, the biggest thing with the hematoma is that it's a really big bruise. So what happens with bruising or contusions, bruising, contusions? You have swelling, right? You have a pulling of blood. Well, if that occurs at a bigger level or in a bigger area, which is a hematoma, that bruising and swelling can obstruct blood flow and cause more tissue damage. So that's why hematomas tend to kind of be a big deal sometimes. Okay. So bruising may be indication of internal injury or internal bleeding. So yeah, so if you ever see as a bruising or discoloration, especially in the abdomen, it's good to suspect that there may be a rupture or a laceration in an organ in that area, in the abdominal cavity. And again, the mechanism of injury is the picture that you see. So if I were to walk up to a car accident, as I'm walking up to the car accident, I see a 24-year-old female that is hunched over the steering wheel, and they have a broken window shield or it's cracked or shattered. When I take that patient and I evaluate that patient, I'm going to assume that if they have bruising in their abdomen, that the mechanism of injury was that steering wheel. And if there was enough force to hunch that patient over the steering wheel and shatter that window shield, then I'm going to suspect that there could be pretty bad bleeding in this patient, hemorrhage. Again, they have internal hemorrhage, and I should be prepared to treat this patient for shock because of the mechanism of injury and what I see on the patient themselves. Crush injuries are difficult to identify. See patient care. So of course, especially during trauma situations, you want to take standard precautions, BSI. You don't want to get any blood on you. And we always want to make sure the patient's airway is patent. They're breathing adequately, and they actually have circulation. We don't want to let any horrible looking injuries get in the way of us making sure that our patient is alive and is going to stay alive. So always go back to your ABCs. Always reassess that, even if it's at a glance, just to look at your patient real quick while you're treating the patient. If you're like, let's say for example, you're stuck on an injury and you're bandaging the patient, you always want to kind of keep the patient's mental status and airway, breathing, and circulation in mind at the same time. So always manage as if there is internal bleeding, and shock if there is any possibility of internal bleeding or internal injuries. All right, so now we're going to open wounds. We should know what that is by this point. So all of these are different types of open wounds. And I'm going to go ahead and give you guys a few seconds. If you don't have these, please write them down. Abrasion is a fancy word for a scrape. That just means scrape. A portion of the skin was scraped away. A good example of this would be a person that would be riding a motorcycle. If they weren't wearing a shirt or they were just wearing a tank top and they fell off the bike as they were driving it and slid on the pavement, they would have a pretty bad abrasion on their body, on the torso. A laceration means a cut. So, and it's just a fancy word for a cut. That's all that means. Penetrating trauma and punctures. That's pretty self-explanatory. That means something went through the patient. When you hear the word of avulsions and amputations are kind of similar, to where avulsions means that there's a tear, like a piece of tissue got torn off the body. That could be partial or complete, but it's a tear. And amputation really refers more to limbs. So a part of a limb was cut off. Okay? So go ahead. I'll give you guys a few more seconds. Write these down if you haven't done so already. You need to know the different types of closed and open wounds. But now, and also obviously know exactly what they are and how to treat them. All right, there should have been enough time to write those things down. All right, so you also have a crush injury. Talked about it in the closed injuries section or closed wounds. It just means that because of the crush injury, the actual skin opened up. Bite wounds would obviously be also open. Blast, we talked about that, so you guys have an idea of how that can cause an open wound, right? From the physical impact of the body slamming to the ground or the wall, or even from the shrapnel that's spit out from the blast itself. And high pressure injection injuries would be from pressurized machinery, most likely. So go ahead and write these down as well, and then that should be all the different types of open wounds you'll come into contact. You guys need more time, or you guys good?
Good.
Good. All right, here we go. All right, so patient care. So what do we do for these wounds? First off, we want to expose the wound. We want to make sure that wherever the patient is complaining of the injury, we want to expose that section completely and get a real good visual of what we're working on. Now, if it's an open wound, we want to clean the surface. Now, this doesn't mean that we have to get super clean like in a hospital. We just have to be clean enough to where we can see what we're doing and get as much debris off. Because when they go to the hospital, they'll make sure that they take care of cleaning out the wound and making sure that there's no infection or taking care of any infection. Obviously, after that, we want to control the bleeding if there is bleeding. Our go-to for bleeding control is always going to be direct pressure. That is our very first thing to do is direct pressure. After that, we bandage the wound if that helps. If not, then we proceed accordingly depending on where the site is. See, for all serious wounds, provide care for shock, including administration of oxygen concentration. Prevent further contamination. All right. See, bandage dressing in place after bleeding and control. So I'm pretty sure I talked about this last class. But once you apply that dressing onto your patient's wound, you do not take that dressing off. Who can remember why you do not take a dressing off that you have already applied onto your patient? See, Desiree.
Yeah, that clot's already formed, and if you rip off the bandage, you're gonna rip the clot off, and then it's just gonna bleed again.
Perfect. Not only are you gonna take off the clot that's already formed, but because it's gonna stick to the bandage, that whatever is already clotting, you're also gonna tear off additional tissue and cause even further damage. Good job. See, keep patient lying still, reassure patients. Okay. So treating specific types of open wounds. Here we go. So reduce wound contamination. We talked about that. Hold direct pressure to control. We talked about that. Always check pulse, motor, and sensory function distal to injury to assure function. So just as you guys would check for circulation, motor, and sensory when you guys were putting your patient on a longboard and a KED after you did it, just it's the same concept. After you've bandaged up a limb or any section of the body, you want to check the distal pulses from that injury itself. And you want to make sure that your bandage or whatever you did for the patient did not cut off circulation. That's the whole point behind that. For penetrating objects, usually you'll leave them in place. So I'm just gonna go, we see bullet by bullet. Use caution as objects may be embedded deeper than they may appear. Check for exit wounds, may acquire immediate care. So yes, you always wanna check for exit wounds, and see, bullets can fracture bones as they enter. That is true. That is true. I don't see how that would really help you out, but that is true. Stab wounds are considered serious if in a vital area of the body. So the thoracic cavity would be very vital because you have two vital organs there. You have your heart and your lungs. Now, as far as for penetrating objects, oh, I'm sorry, I was thinking about impaled objects. So penetrating objects just means that the bullet or the object went in and out of the body. That's usually what that means. Usually they always go out, but that's not always the case. But usually it is the case. If it's a bullet, it's always just gonna be an exit wound, unless we're talking about a smaller caliber bullet like a 22, maybe even a 9. If it hits a bone, there are cases where it will just shatter bone and the bullet may stay inside the body. That is also a possibility. And with the stab wound, so if the patient has an impaled object, let's say the knife is still in their stomach, you don't know how long that knife actually is, and you don't know if the knife was impaled as it was found or if it was impaled at an angle and then straightened out. So be very careful with that as well, and there's always a potential for more injury with these patients. So we want to reassure the patient, search for exit wound. We talked about that. There may not always be an exit wound. Assess need for basic life support. Okay. So bullet travels an unpredictable path once they are inside the patient's body. And this is mainly if it hit a bone. That's when you really don't know what happened. But the biggest thing besides the actual trajectory of this bullet, the path of the bullet, is that there's something called cavitation. So cavitation is when a temporary cavity is formed. So a cavity is like a big space. So when you have you have cavities in your teeth, that means you have holes in your teeth, right? It's a cavity, it's a hole. So when a bullet travels along the body like this, it's going to make that bullet has force behind it, right? So it's gonna create wave forces that go outward. They're gonna spread outward from the bullet. It's gonna spread this way and it's gonna spread this way. And that forms a temporary cavity. Well, because that cavity is formed, now the tissues around the pathway of the bullet are gonna be compressed. So not only is there the actual pathway of the bullet, which there is going to be physical damage, but also there's secondary damage from that force, and it could cause tearing away from the actual bullet pathway. So that's one thing that you should also know about penetrating traumas. Gunshot wound. So here's a patient with a gunshot wound. Okay, so now we're going to impaled objects. So impaled objects are objects that did penetrate the body, but are still in the body. They're impaled inside the body. Again, we want to expose the area, control perfusion, direct pressure as needed. And then with impaled objects, what we're going to do is we're going to give bulky dressing. We want to secure the object to the bulky dressing, or we want to pat around the object to kind of make more sense. And again, this lecture is something that we're going to have to go over in person when we see each other to really get a better understanding and get some hands-on. But I'm going to try to do my best to kind of just talk through it. But an impaled object, you want to stabilize that in place. Like it says here in this bulletin, apply several layers of bulky dressing so dressing surrounds the object on all sides. Secure dressing in place. Now, there is no set protocol for this. You just make it work however you can make it work, because impaled objects can go in any part of the body, and you just have to just make it work. You know, put the bulky dressings wherever it makes sense. Strap it down to wherever it makes sense. Obviously, the patient's going to be bleeding, so we have to prepare to care for shock. As an EMT, all we can do for shock is give them oxygen, keep them warm, and position in a position of comfort. And it's just situational depending on where the impaled object is, how it happened, where it happened. Keep patient at rest. Keeping them at rest does keep them calm too, so that's why that's really important. So here you go. So there's an impaled object on the forearm. So it's a good little example. It shows you, here's the object, and these are the bulky dressings. So a bulky dressing is just, it's a general term for any dressing that's sterile, that's bulky, that can be used. And in the back of your rig, you'll have several different types of dressings. You'll have big dressings, little dressings, bulky dressings. And then you just use whatever you see best fits your scenario. And then here they are, securing the bulky dressing onto the actual extremity. And you have to make sure you leave room for the object to protrude out so you don't cause more damage. So why would we not want to take out an impaled object? Who can tell me?
It can cause more damage.
Yeah, so you can cause more damage on the way out. And also, the impaled object may have actually stopped bleeding. So if you take it out, now you're going to open up a clot. So that's why. See, we'll go ahead and take a little 10-minute break right here, guys, right? So I'll see you guys in 10 minutes. Can you guys see the PowerPoint again?
Yes.
Okay. All right, so impaled objects in the cheek. The biggest thing with this is that you want to watch out for bleeding inside the oral cavity, because that could lead to the patient aspirating, and also we can't swallow raw blood, right, without vomiting. So
I
if
can't
that,
see the PowerPoint.
oh no, okay, let me reshare again. Resume share. You see it now?
Yeah.
Okay, cool. All right, so the biggest thing with impaled object inside the cheek is that you want to watch out for bleeding within the oral cavity, because that could lead to aspiration and also vomiting and nausea, like it says here. And that's because your body, we're not made to digest raw blood. So that's why. External wound care will not stop flow of blood into the mouth. So you want to examine the site, both inside and outside. Obviously, look for any bleeding, and if there is bleeding, stop the bleeding. If you find the perforation and can see both ends, remove the object. So if it is easy to do it and it won't cause that much damage to the patient, by all means take it out, because if the patient's talking or any little thing happens to that object, it could cause bleeding to occur, even if it's not already bleeding. So your best bet would be to take it off if it's small and it won't cause too many issues. Take it out, and then you can put some gauze on the inside between the cheeks and the gum, and then on the outside, and even have the patient apply pressure on the outside of that the injury. So that's one form of an impaled object in the cheek. So like it says here, allow for the patient the blood to drain. So you would want to put him in a recovery position on their side if there is no spinal damage done. That'll help out the patient, at least for drainage, and so they won't asphyxiate with their own blood or become nauseous from swallowing that blood. So obviously the airway is going to be a very big deal for this patient, and we want to be a little extra attentive with the airway because the trauma was in the oral cavity. Dress outside the wound, and obviously give them shock. Give them oxygen. I'm sorry, oxygen. Like any other impaled object, if we decide to leave it in there because we think that taking it out might be too much of a big deal, then stabilize it in place however you can. So for an impaled object in the eye, same concept. Try to stabilize it with either bulky dressing, or you can also use a cup, a little small paper cup, the ones that are used for to get water from the dispensers, the water dispensers. If you poke a hole on the very bottom of that cup, it can be used in place of bulky dressing. And this is an example right here, so you can use this. If the impaled object is longer, obviously you would want to make a hole on this side, so that you don't compress it down any further, obviously, and it's secured in place. And again, there is no set protocol for securing objects in place. It's just however you can make it happen, make it happen. So what's an avulsion again? What did I say that was?
That's when something is kind of torn off.
Yes, it's a tear. So something is torn off. Exactly. Good job. Avulsion. So this is how to treat an avulsion. So clean the wound, the surface. Obviously, it doesn't have to be super clean, but take off as much as possible without spending too much time on it. And then you want to put whatever was torn off, if it's still attached to the body, put it back in place, and then control the bleeding and dress it as needed. Okay. And like I said, the reason we don't really have to focus too much on leaving it super clean is because when you get to the hospital, they'll take care of that for the patient there. For an amputation, this part is going to be completely cut off the body. You can try direct pressure, depending on the location and what is actually amputated. But if it's severe bleeding so bad that you just know that direct pressure is not going to help out, it's okay to go to the tourniquet and not waste time with direct pressure. Who here remembers where I apply a tourniquet in comparison to the actual injury site itself?
It's 2 inches above.
Perfect. 2 inches above the wound. What if there's a joint 2 inches above the wound? Then what? Like if the injury is 2 inches below my elbow, we don't want to
above the elbow.
Above the elbow, right? Because if we put a tourniquet on a joint, it's gonna be dislodged. It's gonna come off from too much movement. Good job. So as far as care for an amputated part, so you want to wrap it in sterile dressing, and if you can, put it in a Ziploc baggie. That's probably also a good idea, and keep it cool. But the biggest thing is you don't want to put the amputated part, the body part. You don't want to put it in direct contact with ice. You want to wrap it around something and then put it in there. Do not immerse amputated part directly in water or saline, either. So for burns, there's three classifications of burn. You have your first degree, second degree, and third degree, and we'll go into it in a bit right now. See, may involve more than just the skin, obviously, because we have organs, we have muscles underneath the layers. So depending on how severe the burn was and how long it lasted will dictate how much damage there is and where it is and how far down the damage is. So if respiratory structures are affected, swelling may occur. Now, if swelling occurs, that's going to prevent our patient from breathing adequately if swelling occurs in the airway, somewhere along the airway. And of course, this can become a life threat. So that, again, it goes back to not letting any nasty burns or nasty trauma take your attention from your patient's ABCs. You really always want to be attentive and not lose track of what really matters here. So do not let burn distract from spinal damage or fractures. Classifying the burns, the agent, the source, the depth, and the severity, they all matter as far as classification. So such as chemical and or electrical burns, report the agent and when practical, the source of the agent. So if you know what actually caused the burn, if it wasn't a fire, it's a good idea to either write that down, document it, and if you can't even take a picture of it, just to show the doctors, give them a better idea of what they're working with. See, never assume the agent or source of the burn. Always be sure of it, okay? Always gather information from your observation of the scene. Okay, we got that down. So these are your three different classifications. You have your superficial, partial thickness, and full thickness. Superficial means that the epidermis was affected. It's the very top layer. Partial thickness means that the dermis, the epidermis, and the dermis, both layers were affected. Full thickness, we're talking about all the way down to the fatty tissue and maybe even the muscle, and in some severe cases, all the way down to the bone. Now, there is a fourth classification of burns, and it's not in this textbook, but you will find it in other textbooks, and that's a 4th degree burn. So a 4th degree burn, which is also full thickness, but there's so superficial, let me back up just a little bit. So remember how I said that there's like two different ways of saying everything in the medical field, that everything has two names? Well, superficial is also a 1st degree burn. Partial thickness is a 2nd degree burn. Full thickness is a 3rd degree burn. But in some textbooks and even just in some places, some hospitals, full thickness has two subcategories, 3rd degree and 4th degree. 3rd degree means that it went down to the muscle. 4th degree means that it went all the way down to the bone. That's what that means. So here you go. Please take a minute or two and write these down. You will come across this again. Again, superficial burn, 1st degree. Partial thickness burn, 2nd degree. And then we'll continue on. So I'll give you guys a minute or two, and then we'll move on. All right, so I'm gonna move on to the next one here. You go full thickness. Go ahead and write this one down too. And if you want to do a side note and then also put 4th degree to the bone. All right, so let's keep moving along with this. So that right there is a first degree burn, also known as a superficial burn. That's the kind of burn you don't normally get when you go to the beach. Now, in severe cases, you can even have blistering with the superficial burn, but that's not always the case. So that right here is a partial thickness burn. You can see how it's like it looks patchy kind of, right? You can tell there's more extensive damage to this patient. This would be done with like an actual fire, some boiling water, things of that nature. Partial thickness again. This one actually has blisters, really, really big blisters. And this is your full thickness burn. At this point, the skin is so tight from the burn that this patient might not even be able to expand adequately to bring in oxygen, because if your skin is so tight, it won't expand and allow your thoracic cavity to create that negative pressure. So as far as estimating the percentage of surface area that is damaged, we have what's called the rule of nines. So the body is divided into different sections, and every section is about 9% of the body surface. Adult body is divided into 11 main areas. Each represents 9% of the body. Now, for children and babies, that changes, okay? And it's on you to go over those and memorize which section is what percentage. So here, I would take a picture of this. So just the thoracic cavity alone, the front is 9%. The back is another 9%. So if the front and back are burnt, that's 18% of the body. Okay, so that's how that works. It's every section. So the section you're actually looking at, and yeah, as the kid gets younger, there's more surface area and it counts for more. So like, for example, the baby's entire head is 18%, and the child's too, but for an adult, the entire head is only 9%. So the geriatric note, moderate burns in a young adult can be fatal for a geriatric adult. This is for two different reasons. One is that geriatrics, meaning the elderly population, cannot compensate as well as young adults. Also, is if a patient can feel a burn, it's most likely that it's a pretty bad burn because their nerves are not working as adequately. So their sensation is diminished, it goes down. So when your adult patient, your geriatric patient is actually feeling the pain, you should really pay attention, because it means that there could be a really dangerous issue going on with your patient. And this also includes burns, obviously. Pediatrics, the issue with pediatrics is that they have more surface area. So they have more surface area than they have internal in the container. Not sure if, okay, let me use a different example. Let's get this baby right here. Let's say that let's pretend that this baby was blown up, right? And we turn this baby into the size of this adult. So this is the adult, and this is the baby blown up into the adult size. What we mean by more surface area is that since we blew this patient, this baby is now grown and we blew them up and they're as big as an adult. In comparison, this adult, let's say that the adult and the baby, let's pretend they're containers, okay? Let's pretend they're containers. This adult is filled up to blood up to this line. I'm just a made up example. It's a made up example. Well, let's pretend that the patient is a container, and from the feet all the way up to the top of the body, the adult patient, only fills up to right here with blood. In comparison, if this was the baby that was brought up to the same size as an adult, in proportion when compared, they have less So let's say their fluid will be down to like right here where the 9s are. They have less internal fluid and more surface area. So that means there's more to burn, but less fluid to compensate. Does that make sense or no? Does anybody want me to repeat that or say that in a different way? Did it not make sense to somebody? Okay, so because of that, the pediatrics, see, infants and children have a much greater relationship of body surface area to total body size, resulting in greater fluid and heat loss. So they have less fluid than they have surface area, so they can lose more fluid as opposed to an adult patient because of the proportion. All right, so treating specific types of burn. See, patient care for thermal burns. So obviously we want to stop the bleeding, cool it down. Always ensure the airway and breathing are good. If they're not, we want to manage that first before we manage anything else, because if we're trying to take care of a burn while the patient's airway is swelling, it doesn't matter how good of a job we do on that burn, the patient's gonna die. So it doesn't matter, it's all for nothing. That's why that's really super important. Obviously, complete your primary assessment. That's where you take care of your patient's airway and manage it and treat for shock. So you want to evaluate the burn, get an idea of whether it's a 1st degree, 2nd degree, or 3rd degree burn so we can treat it appropriately and also document it. Again, we're gonna clear the wound, but we're not gonna be doing a super good job. That's for the hospital to do. We just want to clear it to get a good visual and to not have any debris in there. Take out the debris and secure it in place and bandage it in place how it's supposed to be. The reason that we remove clothing and jewelry is because every time a patient burns or a part of the body burns, that part is going to swell up. If there's jewelry or tight clothes, it's going to constrict that area even more. That's why that's bad. Wrap with dry sterile dressing. You have plenty of that on your rig. For burns to hands and feet, remove patient's rings, jewelry. Talked about that. Okay, the issue with electrical burns is that they burn the patient from the inside out. So initially, the damage does not look as bad as it is. Severe damage to body by disrupting nerve pathways. So the pathway that electricity takes in the body, let's see. I'm gonna use the example of the bullet that was over here. Give you guys a better understanding, I think, of what I'm talking about. Here we go. Let's just pretend that this is the pathway of electricity, right? So this patient got jolted with electricity and it just went, this is a pathway it took for whatever reason. Well, if this is the pathway that the electricity took, what's gonna die first is whatever's along that pathway is dead. It's gonna die, all that tissue. And now your patient's tissue starts to die from the inside out. So over days, this will progress, and tissue damage will occur more and more. And so what initially was just a open wound had an open and an exit wound from the electricity, and it looked like a bullet wound, will progress and cause severe tissue damage because the body and the tissue are dying from the inside out. The electricity and all that stuff that ran through it continues to cause damage to the tissue of the body. So that's the big deal with electricity. That's why that's so scary. Rule of nines, geriatric, pediatric, thermal burns, electricity. All right, so entry and exit burns are possible. We talked about that. Respiratory and cardiac arrest are also possible. There's a whole bunch of electricity running through your patient that is gonna jack up the conduction system in the heart for sure. I mean, there's a good chance. Bones may fracture from violent muscle contractions. ABCs, really important. Treat for shock, give oxygen. Talked about that already. I'm gonna play this video for you guys. I think it's a video.
As electrical current passes through the body, resistance to current flow from tissue, such as bone, As electrical current passes through the body, resistance to current flow from tissue, such as bone, results in the production of heat. This heat is transferred to the surrounding tissues, and extensive thermal injury can occur without significant external signs. In addition, injury to the heart's electrical conduction system is common, and lethal cardiac dysrhythmia possible. As electrical current passes
Okay, so dressing and bandaging is something that I'm gonna have to go over with you guys in person. But we're gonna take a little 10-minute break. Or I think this might be our last 10-minute break, and then I'm gonna show you guys a video, maybe one or two, on dressing. And it's really not gonna do you justice because you have to get your hands on it. You really do. But I'm gonna try to see if I can find some decent videos that make up for it. So I will see you guys in about 10 minutes.
My name is Av Rios, and I'm a paramedic with Lansing Mercy Ambulance on behalf of Expert Village. In this clip, we're going to go over making a pressure bandage for an injury such as a laceration or a deep cut. This is my partner, Jacob Barber. He also works with me as a paramedic for Lansing Mercy Ambulance, and he's going to be doing this on behalf of Expert Village. What we want to do in this situation is control the bleeding. We're going to start by taking a bandage or a dressing. We're going to take our dressing, and the first thing we're going to do, if this is our injury site, is hold direct pressure and elevate the extremity. What we also want to do is keep the direct pressure. It's more practical for me to tie something here to hold the pressure for me, rather than me to use my resources to hold my hand here the whole time. So what I want to do is use something such as cling. This is a bandage. What we're going to do is put this on there to work as holding the pressure for me. It's important that when you're bandaging, because you're going to be making this tight, you want to make sure you work distal to proximal. Distal meaning furthest from you, proximal closest. So you want to start at the wrist, and as you work your way closer in. The reason for this is because since you are going to be making this tight, you don't want to push blood into the hand and trap it there. You'd rather go the other way around if possible. This is an adequate dressing right here, and what I can do now is tuck it in by cutting this. But what I'm going to show you also are some different ways that you can help make this a little bit tighter, because usually the more pressure you have, the better chance you're going to stop the blood flow. You can do something which what we do is you pull it out, and you're just going to rotate the cling. What this does is going to reinforce this, makes it a little bit stronger, and you can pull harder. By doing that crossing motion, it makes it stronger and less flexible than this normal cloth. Again, when you run out of cloth, you can just cut this, and what you're going to do is just tuck it underneath, such as this, eliminating this top part. If for some reason this ever becomes blood-soaked and the blood is coming through it to the point where it's no longer controlling the bleed, you want to make sure that you never take off the dressing, but rather just put new bandages over this one. But you never want to take off the original one once you have it on.
Lit Mobile just sent me this wireless solar power bank. Let's see what's inside. Power bank has 20.
Did you guys hear that?
Yes.
Yes.
Awesome. Okay. I think that's gonna be it. The rest of all of this, no, we already passed this stuff. We did burns. We did that. We did electrical injuries. We did that. So the dressing part is the last section. We just have like these last 5 slides right here that you guys see on the side. That's all we have left. That is all stuff that we are gonna talk about in person when you guys see me next month sometime. So we'll cover that next month. Besides that, I don't have a Kahoots for you guys, so we're pretty much done with today's lecture. That's gonna be it. Unless you guys have any questions. Nope. All right. Well, I will talk to you guys on Tuesday next time. All right. And the chapters we're going over are gonna be chapter 27. It's gonna be chest and abdominal trauma. If you guys don't have anything, good night. That's it for me. Good night.
Thank you. Good night.
Good night.
Good night.